Welcome everyone to the Community Health Nurses of Canada webinar series. This is our fifth and final for 2022, unless we organize some further webinars later in the year. My name is Donna Jetson. I'm the president of the Community Health Nurses of Canada. I would love to just take a second and wish everyone a happy National Nursing Week and International Nurses Day. It's a special week for many of us, and I hope people are taking the time for some reflection and some celebration. And we're so happy to be hosting this webinar today on during National Nursing Week. I'm calling in from rainy Vancouver today, and this is the traditional territory of the Musqueam, Tsleil-Waututh and Squamish Nation. I'm grateful to be working on this land today. If other community health nurses that are on the call today would like to add their territorial acknowledgement from where you're calling in from today, please feel free to put that in the chat, and the rest of us will be able to read that. I will now turn it over. Oh, just before I do that, I also wanted to put a plug in for our national conference. You can see the slide, which is coming up on June 8th to 10th. It's a virtual conference. And our executive director, Anthony, just told us that there's already 150 community health nurses that are registered, but there's room for others to attend. And the sessions will be available for 6 months after the conference in case those dates don't work for you. So this is an open invitation to all to attend our national conference. So I am going to turn it over to our team of presenters today. They are going to introduce themselves because there's 5 of them today, and tell us who they are, where they work, and their role. And all the members presenting today are members of the Community Health Nurses of Canada Leadership Standing Committee. So Ruth, maybe I will turn it over to you, and you can decide the order between you, May, Kathy, Genevieve, and Patti, who wants to introduce themselves. So I'm going to go on mute now. Thank you and welcome.
Thanks, Donna. It's a pleasure to be with you today, and happy Nurses Week to all of you as well. And we were very fortunate to be able to have the opportunity to share this study with you. So on this special week that we're all celebrating. So welcome to this webinar entitled Health Inequities and Moral Distress Among Community Health Nurses During the COVID-19 Pandemic. As was mentioned, I'm Ruth Schofield from McMaster University, and we are all members of the Leadership Standing Committee. We will briefly introduce ourselves. So we'll go from west to east. So I'll begin with Genevieve.
Good afternoon, everyone. My name is Genevieve Currie. I'm from Calgary, Alberta, and I'm a long-term public health community health nurse and currently teaching nursing at Mount Royal University.
Great. Kathy?
I would be next in Manitoba. My name is Catherine Baxter, and I'm an assistant professor at Brandon University, which is a small university about 2 hours outside of Winnipeg. So nice to see everybody today.
And May?
And hi, everybody. And my name is May Tao, and I worked in Toronto Public Health. And I worked as a health promotion specialist, but actually in charge with the best practice spotlight organization for our organization. Thank you.
And Patti.
Hi, everyone. My name is Patti Gauley, and I'm the Chief Nursing Officer and Director of Health Promotion at the Eastern Ontario Health Unit in Cornwall, Ontario. And it's a medium-sized public health unit. Thank you.
Wonderful. So that's the team that's presenting today. And so this study is a collaboration between Community Health Nurses of Canada, the National Collaborating Center of Determinants of Health, and Brandon University. In this webinar, we'll share the findings of the study and encourage you to attend, as been mentioned, to also attend the conference, which Donna has kindly mentioned. At that time, we will also be discussing further our study. And we do have an open session that is really focused on the solutions and leadership competencies that we'll touch on today. Next slide. So before we go forward, I just want to acknowledge as Donna has done, the land acknowledgements for all of us presenters, because we all live across Canada. And so on this slide, you can see all the acknowledgements from each of us. Next slide. As noted, we are members of the Community Health Nurses of Canada Leadership Standing Committee, or the Leadership Institute, and the research team, as you can see, and that the research team is basically are all members of the Standing Committee. In addition, because of the collaboration with the National Collaborating Center, Daniel McDonald, who is a knowledge translation specialist, also joined our team during the study, and we've had support resources from NCCDH in order to implement this study. And in fact, we do have an RA, which we missed, but she is also participating and helping us with the study, and particularly in the dissemination strategy. Next slide. So just a little bit about our standing committee. Of course, the mission of CHNC is we are a national organization, as many of you know, of community health registered nurses that are to advance and to improve the health of Canadians. The Leadership Standing Committee purpose is to develop and implement a continuing education program on leadership for community health nurses, and hence the focus of our committee. Our objectives are to be a hub for professional development and knowledge translation, and support evidence-informed practice, cultural humility, and integration of the public health leadership competencies. And of course, that's embedded into CHNC's strategic plan. Next slide. So what we know. So the Standing Committee gathered some anecdotal data in 2020 from community health nurses about their experience during the pandemic. Based on these stories that we heard, we decided to explore this further in this study. We learned that a survey conducted in the fall of 2020 by the Association of Regulated Nurses of Manitoba, in collaboration with Community Health Nurses of Manitoba. This study showed high levels of moral distress among community health nurses. One major source of moral distress reported was the inability to meet the needs of vulnerable populations, as limited public health resources were redirected towards a pandemic response. The Leadership Standing Committee decided to adapt this study for a national audience. Next slide. So our research questions were to really understand, or what were the experiences of moral distress among community health nurses during the pandemic. Another research question is, what are the factors that contribute to moral distress among community health nurses during the pandemic? Then the third research question is, how do health inequities among client populations contribute to moral distress among community health nurses during the pandemic? And what solutions are identified by community health nurses to address these inequities? And what are the leadership competencies, and what leadership competencies enable community health nurses to enact the solutions? So these are the purposes that have evolved out of these research questions. Next slide. So we did the design was to include a national online survey using a snowball sampling technique among community health nurses. The survey was open for 6 weeks, in June and July of 2021. To give some context of the pandemic, we were in the third wave at that time and beginning to roll out mass vaccine rollout. And despite these circumstances, we had 270 responses with a total of 245 that completed the survey. The participants included from the Western Canada, 57, from Central Canada, 126, but we didn't receive any from Quebec, Atlantic, 52, and Northern Canada, we had 10. There were 239 that identified as female, 7% were self-identified as Indigenous, First Nations, or Métis, 8% identified as members of visible minority. The practice settings included 65% from public health, 17 from primary health care, 12 from other like education, and 6 from home health. The geographic breakdown was 62% from urban and 38% from rural. We felt it was really important to get a sense of where people were in terms of community health nurses. Of the urban participants, 48% were urban other and 52% were urban inner city. Next slide. The nursing experience based on years of experience as a nurse and years as a community health nurse, we had, in terms of years of RN experience, which you will see in the orange, the deeper colored orange, 45% had over 35 or 31 years of nursing experience. So it's certainly a large number that had been practicing for a number of years. However, as you can see, those actually, I think I need to correct myself. Years of experience is the light orange. Years of experience as community health nurses is dark. I see your smile, Kathy. And so a large number had lots of experience in being RNs, but in community health nursing experience, 45% had under a year and a half experience. So many did not have much experience. 45% were 11 to 15 years of experience. In terms of solutions, oh, sorry. So we'll move on to next slide, and Kathy will take it from here.
Thank you, Ruth. So I'm just going to walk you through a few of the findings, and we're just going to touch on some of the experiences that we heard about in relation to moral distress. And what I'm going to do is I'm going to present, and as we go through the presentation, present the slide with the findings, and then we're going to present some of the direct quotes, the voices of the community health nurses that responded to our survey. So just a quick summary of what the findings in relation to moral distress showed. So we identified a number of constraints that were specific to the COVID-19 pandemic. So things that restricted and constrained the nurses' ability to carry out their roles. And those constraints led to an amplification of existing inequities. So the inequities that existed in society became more pronounced and amplified and of greater significance. And those, the combination of the constraints, the amplification of the inequities led the nurse to moral conflict. And that moral conflict then led to moral distress. But interestingly, there were additional factors that contributed. So moral conflict alone wouldn't necessarily have led them to moral distress, but moral conflict, when attached to compounding factors, and I'll explain what those are in a minute, increased the level of distress that nurses experienced. So I want to walk through each one of those fairly quickly. So in terms of some of the quantitative responses and the constraints that nurses identified, we see that between 76 and 84% of nurses identified that they were unable to provide optimum care, that they had to prioritize COVID-19 over other high client needs, that they had to delay necessary interventions, or that they weren't able to provide the necessary interventions. And the constraining factors were related to workload and the available time that they had in order to carry out those tasks. When we asked qualitatively for them to tell us a little bit more, we got pages and pages of data. So some of the constraints that the nurses identified again were heavy workloads. So a workload that just didn't allow them enough time to do everything that needed to be done. The continuous refocusing and redeployment. So nurses being redeployed to different areas, having to refocus their workload, and that happening not just once, but repeatedly. Caused certainly issues in relation to them being able to do their job. The presence of an existing inequities. So it's one thing to ask someone to isolate at home, but that becomes very challenging when the individual has no home. And so those existing inequities, how do you contact a client over the internet if they don't have access to a computer? The presence of public health orders and government policies. So public health orders were put in place and they restricted the nurses' abilities to make home visits. They dictated a great deal of how their workday was going to be spent. And in some cases, government policies didn't keep up with those public health orders. So we had mandatory stay-at-home orders, but there wasn't government policies to support paid sick time. So people were having to stay home when those additional government policies weren't in place. And that was especially prevalent earlier in the pandemic. And then the whole concept that we reacted as opposed to acting proactively. So we reacted to things as opposed to having proactive plans in place. So in the voices of the nurses.
One nurse said, "Sudden shifts in practice with a vague email that comes a day or two before the change happens. Not being asked for input, having a call center complete your work feels like garbage," end of quote. Another nurse said, quote, "Not being able to help as there was not enough resources to help those in dire need and circumstances. Hearing and reading about people losing their jobs because they quarantined, self-isolated, people being evicted from their homes with their families, students with special needs and learning exceptionalities having difficulty adjusting to online learning, families and children who were experiencing abuse at home pre-COVID were put at greater risk of abuse and neglect," unquote.
So all this led to the amplification of existing inequities. And the three areas that the nurses identified as main areas of concern was the disproportionate impact to persons in situations of marginalization, whether those individuals were inadequately housed, living in poverty, or living in rural versus urban communities. We also saw a widening of digital inequities. So everything went online and that was great, but libraries closed. And if that was your only access to a computer, you didn't have access to those resources. And the accessibility of services. So the super sites being located downtown or on the edges of cities were perhaps difficult in terms of transportation for people who didn't have cars, or the lack of accessibility of services in rural areas. In the words of the nurses.
One nurse said, quote, "Newly immigrant families and temporary foreign workers often do not have adequate means of contact. Example, no access to cell phones and language barriers, as much information was not translated in other languages," end of quote.
So all of this led to multiple sources of moral conflict, and we categorized them into 8 areas. So the nurses identified moral conflict in the area of having to work with clients and implement public health orders when there were unsafe and inadequate isolation conditions. The unmet needs of clients when they didn't have time to do everything within their workload. The constantly changing and uncertain landscape. So this ambiguous place of one public health order today, another public health order next week. And that all stemmed from the constantly changing information that we had about the virus. So our orders changed as that changed, but it was constantly changing and uncertainty. Threats to quality of care, and that was often described in relation to concerns over the private sector or coming in and a business model being introduced versus a public health model. The negative impact of public health orders on some, and that's the principle of do no harm. So examples there would be requiring someone to self-isolate in a home where there was a known situation of intimate partner violence. So concerns over those issues. Queue jumping and vaccine prioritization. Stories of if you know the right person, you manage to sneak your way up to the front of the vaccination line. One size doesn't fit all. So the need to tailor, that public health nurses had the knowledge, but they didn't have the power or the control to tailor public health orders to the needs of individuals. And a sense of futility, that it didn't matter how much they did, how hard they worked, that was never enough. They couldn't get through. So in their words.
One nurse said, quote, "The staffing of immunization centers, not applying protocols, not working to well-established public health immunization standards, not adhering to policies, practices, or imperatives such as the 7 rights of the client being immunized. Even more basic, not landmarking the belly of the deltoid, being applauded by leaders for productivity over proficiency, and competing for coffee cards for the highest number of immunizations per shift. Safety is sacrificed, client needs are ignored. All my efforts of raising awareness and correcting practice are discounted and ignored," end of quote. And another nurse said, quote, "I have been distressed to find families who did not have enough food or money for essentials. Some were hungry. I found it frustrating searching for solutions to hear time and again help would arrive via the food bank next Friday, or after an application for financial support, or to contact so-and-so, maybe they can help, when they needed food and essentials that day. How can we dare to ask people to isolate and quarantine and not have immediate help for them when needed?" End of quote.
So as I mentioned earlier, the moral conflict was present, but what made it worse? What made the situation worse for these individual nurses were these compounding factors. So when the recognition that pre-pandemic health system constraints existed, they were staffed before they went into the pandemic. They were even more short-staffed during the pandemic. When there was ineffective leadership, management, or communication, that made their voices feel unheard, and it made the situation worse. Constantly hearing on the other end of the telephone clients who were in denial, angry, very critical, or in a lot of distress, and that just wore them down. Personal and family factors. So they weren't just worried about their clients, but they were also worried about the safety of their children at home, their parents and grandparents. And that combination of working with COVID all day at work and then having to go home and everything was COVID at home as well, was also exhausting. And sense of safety at work. So the availability of personal protective equipment, especially early on, a sense that there was support for their own mental and physical health was important. In their words.
One nurse said, quote, not having a say, not being listened to, decisions being made by the organization without future planning, having to tell people who live without that I couldn't be around either, having to tell the groups that I work with that they were not considered a priority, not being provided information by the employer, more a trust me, I know best attitude, not being used for my intangible strengths, none of us having a say, end of quote. Another nurse said, quote, when my manager wanted me to only give the staff below me 1 mask per week, wearing the same mask all week to different clients, and taking the mask off throughout the day for drinks and or food, end of quote.
So all of this led us to the question of, were they experiencing moral distress? And 80% of the nurses who responded to the survey indicated that yes, they were experiencing moral distress. And of those, 75% indicated that the source of their moral distress came from the presence of working with individuals in experiences of marginalization or with inequities. The perceived level of moral distress for 80% of individuals was perceived to be higher than it was pre-pandemic. And when we asked them to gauge their level of moral distress using the moral distress thermometer, a remarkable 53% of individuals identified that the distress was at the level of distressing, intense, or worst possible. So they were in a fair amount of discomfort from a lot of the distress they experienced. So the literature tells us that moral distress can be associated with compassion fatigue and exhaustion and burnout. And certainly we heard comments that would, we weren't looking for these things, but we heard comments that would support that nurses are feeling that. But the other side of moral distress is that it can actually drive you to action. And one of the questions we asked on the survey was, what are some of the potential solutions? And they had many. So I'll turn it over to Ruth for the last part of the presentation.
You're muted.
You have to unmute your mic, Ruth.
Yes, that always helps. Thank you. And I think that was an important piece that we really wanted to know in this study, was what were solutions that really address the moral distress and the inequities that they were seeing and hearing during their day-to-day work life and beyond. They told us these 5 solutions. The first 2, as you can see, really land on the health equities. So they talked about advancing health equity, expanding relationships and partnerships. So those 2 really landed on the addressing the inequities. In terms of the latter 3, strengthening leadership and management, ensure quality care through professional nursing practice, and enhance safety, health, and wellness of nurses, really looked at building a stronger community health nursing workforce and solutions necessary in those areas. So moving on, in the next slide, we identify or describe a little bit more what they were telling us about in terms of advancing health inequities. And they identified all these various components of what that meant. And we'll hear from the voices of the nurses now.
One nurse said, lack of safe, suitable, and affordable housing is very problematic in the province. Food insecurity and lack of access to appropriate social supports is also problematic. Guaranteed basic income and access to housing would both help with reducing inequities. Another nurse said, specifically for the disparities I encountered during this pandemic, would recommend a systemic understanding of the disproportionate burden quarantine or isolating has on the population that doesn't meet even the basic social determinants of health. Back to you, Goose.
Yeah, moving on. And the second solution, as was mentioned, is the expanding community relationships and partnerships. And you can see here, it jumped out very loudly in terms of how relationships were existing or could exist or were existing. So we'll just hear from the voice of the nurses on this solution.
One nurse said, work to create community programs with several different layers so that clients can turn to other organizations or program when one program cannot be available as before. Wrap around clients in the community so they always have somewhere to go and have their needs met. Another nurse said, outreach to staff and community partners to begin to re-image what our work can be like post-pandemic. It is an opportunity to build our programs in a new way.
And the next solution focused on strengthening leadership and management. And they identified all these different ways that management and leadership, and they made a distinction between them. And so we'll hear from the nurses now.
One nurse said, quote, better leadership at the top and throughout the entire complex of Canadian public health in order to make health equity not just a choice, but a conviction of necessity, end of quote. Another nurse said, engage others. Frontline staff have the answers to a lot of the issues experienced in the clinical care setting. By allowing frontline staff the autonomy to direct change will in the end be better for client care, increase morale, and decrease moral distress. End of quote.
Thanks, Patti. And the next solution looked at the whole aspect of quality care, and they were saying ensure the quality of care through professional nursing practice. And you can see a number of points here that really speak to this particular solution, and we'll hear from the voices of the nurses. Recognizing we are not including all quotes because we don't have time to share that. So I think I just wanted to highlight that as we talk about our quotes in the voice of nurses, there's a lot more they told us, but we're really just honing in it because we don't have enough time to share everything. So go for it, Patti.
Okay. One nurse said, quote, to start to have some staff time discussions and planning that is focused on non-COVID care and initiatives. COVID does require time and resources, but we cannot ignore all other health issues. We need to restart programs and supports that are non-COVID supports, especially in the areas of harm reduction, chronic disease management, and mental health, end of quote. Another nurse said, quote, listen to the staff's fears and concerns and do something about it, not just brush it off, end of quote.
Thanks, Patti. And the next, the last solution looked at enhance safety, health, and the wellness of nurses. And we heard them tell us this in these three areas, the themes that jumped out. And so we'll hear the voice of what the nurses said.
One nurse said, quote, stricter legislation and enforcement for employers that jeopardized worker safety. End of quote. In the SARS Commission report, Justice Campbell referred to the precautionary principle. And that means to initiate preventative actions to reduce risks, even though scientific evidence might not be available. Justice Campbell also recommended that in future disease crises, where the disease is unknown or it's a new disease, that the precautionary principle be used. End of quote. Oh, that wasn't a quote. Sorry, I'm just explaining precautionary principle. Second quote from another nurse, quote, be aware in order to combat moral distress experience End of quote.
Thanks. And then one of our last questions was, what leadership competency or capabilities would enable them to achieve this solution, considering two different leadership frameworks, the public health leadership competencies that use the LEADS framework and the actual LEADS framework. And these are the 5 leadership competencies or capabilities in this framework. So there's system transformation, engage others, develop coalition, lead self, and achieve results. And you can see that 40% of the community health nurses, or I should say 40% of the responses were about system transformation. And that engaging others and developing coalitions, there were 27% of the responses related to these competencies or capabilities. And that 12% reported lead self, and 9% with achieve results. So you can really see that these first few of the competencies were really that stood out very strongly to community health nurses that would enable them to achieve these solutions. So we asked them to delve into that further, and this was the last question. And we asked them to elaborate on their choice. And this is what we heard. The focus was on system transformation and building community partnerships and coalitions. So it was the what and the how. And the system transformation really pulled out these 3 areas: having leadership or being leaders in addressing the root causes of inequities, being leaders in to leverage opportunities with public health resources, and being leaders to assign action with public health priorities. So this is what we heard in terms of the solutions, and we really wanted to have the study to end on not just sharing their experiences, that you've heard very rich voices of their experiences during the pandemic, but what were some of the solutions? So I think this is a very powerful way that ended in terms of what they were telling us. So before we end and move on to the Q&A, we really wanted to give a big thank you to all those community health nurses who are willing to share their stories while they're in the middle of the 3rd wave and the mass immunizations that were just moving forward. And you can appreciate the time that they needed to take to respond. And that was 270 of them, or 245 that completed it. So we want to now just open it up to you to ask any questions of us of the study. And so we're just going to leave it open at this point to hear from you. So yeah. And I'm not sure, and I haven't been monitoring the chat. So if there is a question that somebody has said in there, we'll be glad to entertain it. I'm just frankly haven't seen it, but I see Karen's hand up. Go for it, Karen.
Hi, folks. Nice to see familiar faces. Wonderful presentation. There certainly wasn't any surprises there, and really nice to have that research to draw on. I may have missed it in the number of staff or the number of nurses who completed. Did they identify what area of practice, or was it just focused on public health nursing, or was it all areas of community health? I might have missed that beginning, so just wanted to clarify, because certainly to me as a home care nurse, same story, same examples.
Yeah, just to assure you that, Karen, we did. We did ask that question. It was at the beginning, so I can appreciate we've covered a lot of content, so it's probably hard to remember.
Sure, that's okay. I just wasn't sure the context, if it was just public health or if it was all, who would have responded, right? Because certainly I think there's a lot of similarities, definitely in home health, but some of the the system issues may not been as recognized as much for home health. The things that I heard in terms of moral distress was more the staffing challenges and the fear of going into homes, because the home health folks continue to go into homes. So they didn't have programs to shut down and to flip to virtual. So a lot of that was more of the unknown and the changing. I didn't hear a lot of the system issues. It was more the practical day-to-day on the ground, and then the community fear as well. So particularly now, particularly as a pandemic change phases, you know, and as things were starting to loosen up a bit, people were still very fearful of anything. And it was a challenge early on to have the nurses feel safe to do, you know, and this masking shortage. Like I remember I mean, probably everybody, the time when I had to develop an education guide on how to extend the use of your mask. I was like, what am I doing? You're like, this is crazy. But we needed to provide, okay, if you're going to do it, because that's what we're told to do, here's how to do it safely, like with paper bags and in the car. And, you know, we had nurses, not really nurses, more so with the home support folks. They would wear their mask and then they'd fall going up the stairs to like a seniors complex. Because just, you know, you wouldn't think, like, you don't need your mask when you're outside your car and there's nobody around, but they would have the mask on all day. You know, so really interesting. So the moral distress, I think, shifted over the course of the pandemic, but I think it's still a big, we're not out of it yet. So the distress of nurses is still quite high, even though we're in a transition and a maintenance phase. So thank you so much for having this evidence to back up the experiences of community health nurses.
Yeah. There were 6% of the participants were from home health, but you probably heard more from public health because we had 65%. So there was a difference there, but yeah, definitely from home health, we did hear those stories. So yeah, Cindy, nice to see you.
I'm going to say there's a couple of questions in chat.
Okay.
So maybe Cindy could hang on to that thought for a second.
Yeah.
But Jane Hess says, thanks everyone for your great work. Where will the study be shared? And one of the things, we are in the process of developing the knowledge translation materials. So we're developing infographics and a policy brief, and those will be housed on the National Collaborating Center for Determinants of Health, their website. And we're hoping perhaps also available through CHNC. So those resources are in development now. And then there was a question from Donna about burnout. And in the book that you cite about when self-care is recommended, it takes the responsibility away from the workplaces. Excellent point. I will say that the nurses we spoke to were very clear that when they look at self-care, they were expecting some employer buy-in in that. So opportunities for debriefing sessions at work, recognition that employer supports for wellness were, so they were not letting employers entirely off the hook on that piece. So yes, absolutely. So Cindy, I guess.
Yeah, no, I was just going to comment. The other thing we're planning on doing in terms of dissemination is obviously publishing the study. So I think that's another piece that'll get out that hopefully will inform boards and governments in terms of the voice that community health nurses have had. So yeah, Cindy, go for it.
Yeah, thanks Ruth and all for a great presentation. I think it resonates clearly with where I've been working at Peel Region, many of the areas of moral distress that came up. But interestingly, the issue about the leadership and management, I know in our vaccine clinics, and it's purely from a workforce capacity issue, most of the managers in our vaccine clinics were contractual staff, so they weren't public health or community health nurses. I'm not sure about their IPAC knowledge, or you know, that quote from the nurse that said they weren't even going for the belly of the deltoid. I heard many different complaints from our nurses about just how they were treated in, it's just so many layers of stress, but that, compounded it. So I can totally relate to that. But I just wanted to share, I heard a very inspiring presentation from two of our nurses at Peel today who were working to try and increase vaccine uptake in some of our most marginalized areas in Peel region. And it is such hard work, but they worked with faith leaders. They worked with community partners who were established and had trust in the community, because we were not seen as, a government agency, as somebody having trust with these people who've been disenfranchised by policy and so many different reasons. But they worked with those people to increase vaccine uptake. And then the other side of that was they could address some of those other needs that people had when they came to clinics. So it was hooking them up to community resources. And I hope they're going to publish that experience somewhere, because it was really inspiring to hear that amongst all of the negative stories that we've heard. I just wanted to share that. Thank you.
Thanks, Cindy. It certainly again speaks to the leadership that nurses are showing in the community, and the partnerships are, again, the what we heard, as you heard from the solution, is how they were working with others to make this a reality. So yes, that thanks for sharing that story of what's happening in Peel. It would be good if they can publish that. Good. Any other comments or questions anybody has?
There's a question in the chat asking, Patti, this is for you. Could you go over the precautionary principle again?
So essentially, the precautionary principle is to take preventative actions to reduce risks, even though there's no scientific evidence supporting it at that point in time. And going back to the SARS outbreak, that's when, or following that, when the Justice Campbell recommended use of the precautionary principle, because early on in the SARS outbreak, there was a lack of measures that were taken to protect employees. So throughout the current COVID pandemic, what we're seeing is, like early on, I'm thinking when people were asking about mask wearing, and that being a good example of, we weren't exactly sure what was out there, but we were certainly hearing from our leaders in public health to don masks. And the public was doing this in addition to all healthcare workers and others out working with the pandemic. So it's taking preventative measures, precautions in advance of knowing exactly if it's going to help or not, but we know it's not going to hurt us. And I'm not sure if that answers your question.
Thanks, Patti.
You're welcome.
Helpful? Did that answer it, Jane?
Or Donna?
Sorry, Donna. Yeah. Good. Good. Thanks, Jane. She has posted something there. I think that's probably the link to what that is all about.
Yeah. Thanks, Jane.
The public is learning some of the languages in public health, but are struggling with what it all means. And I think we're seeing that continually. And this is one principle that they struggled with. Yeah. So, yeah, Jane, did you want to add to that or have another question?
Yeah, no, I was just adding to that. I think Patti's example, certainly from a public health perspective, was the whole issue with N95 masks.
Yeah.
And at the beginning, there was no evidence to support the use of N95 masks. And certainly that's what the Ontario Nurses Association in Ontario was pushing for. And so a precautionary principle would be that, yes, we would do that. You know, even with the lack of evidence as to what was required for you know, control of COVID-19. So I think we did miss the boat a bit in Ontario sometimes on that using the precautionary principle. And I can admit that now I'm not working for public health right at the moment.
But you sure believed in it, right, Jane?
But I just to add, I think that sense for nurses when they felt that their request for PPE was not being answered or their concerns were somewhat diminished, they felt that they were at risk of bringing the virus home to their family. And so that created tremendous stress for them. And so I do think this whole idea of we don't know whether it's contact or airborne or how exactly it's spreading. So you assume the maximum level of PPE to protect yourself from any source with a new virus. Yeah. And I think nurses would have been very, it would have assisted in those early stages with their comfort level. As we've gone on, our comfort level changes. So I do think it's something we need to sort of hang on to and think about for future planning.
Good point. Yeah, Karen?
Yeah, this is a really great discussion, and I'm glad to have that term now, precautionary principle, because that's really what we use in home care in our professional practice team when we were looking. Because I work for VON, and we were looking at the strategies from both Nova Scotia Public Health and Ontario Public Health. And of course, they were different. You know, we couldn't just go with one thing, right? And I know many organizations had some of that struggle, but we had to look at, okay, what's going on? And early in the pandemic, when Ontario went to all healthcare staff wearing a mask, including home and community care, it was about 2 or 3 weeks ahead of the time for Nova Scotia. Of course, you know, the population and on the epidemiology was a bit different, but we were like, well, we're an organization providing nursing services. We're going to make this so across Nova Scotia and Ontario. And the pushback that we got, you know, because some of the staff saying, well, they're not doing that in the hospital. I said, well, not yet. So it was a lot of, you know, we said, well, Ontario, they're ahead of us. Their epidemiology is growing and they have come out with this. So we're going to make it so in Nova Scotia as well. And it turned out, you know, 3 weeks later, Nova Scotia Health said, oh, by the way, all healthcare workers have to wear a mask in all settings. And then now as we're at this different trend or time of the pandemic, Nova Scotia has said N95s are not required for COVID positive clients now, unless they have an AGMP. But in Ontario, it's still, you wear an N95 if you're caring for someone who's suspected or COVID. So we kept that principle in place for Nova Scotia. And so far, we haven't got any pushback. But the government was like, well, we're not paying for N95s anymore because Public Health in Nova Scotia says you don't need an N95. But we've said, well, we're still providing care, and Ontario, you know, anyway. So far, it's been good, but I know we're coming up to, I think we said we would reevaluate in June to see whether that was still going to be the messaging. So that precautionary principle, we tried to, I didn't know we were using that in place. So yeah,
Great.
Just thought I'd
Good.
share that. So, yeah.
Excellent. And now we're even making them, as Jane says, and brought them.
Yeah.
They're going to be more available in Ontario.
Mm-hmm.
We don't have to go to China to get them now. Yeah. Thank you. Anybody else interested? We do have, as I mentioned, we'll be at the CHNC conference. We will be presenting part of this presentation as an oral presentation. And then we also have that open session where we really have the opportunity to really delve in more into some of the solutions and just how we as nurses in community health can really be leaders in some of these areas and really move forward. Even this principle of precautionary prevention. I mean, these are things that are clear that we value and see as necessary. So that will give us opportunities to think about how we can do that. Do you have some thoughts, Cindy?
Oh, sorry, Ruth. I might have missed it at the beginning. I'm just wondering how to get this recording because I know several of our nurses wanted to come today, but aren't able. Will it be on the CHNC website?
Yeah, maybe Anthony or Donna can speak to that.
Yes, it turns out to be a YouTube link, and I think we have the last one up there.
Is it in the chat?
No, it's not in the chat, but I'd have to figure that out. I think Anthony may have left, or
Okay.
yeah.
It'll probably be on the website, right, Donna?
Yeah, I think so.
Yeah.
Okay, thank you.
Yeah, I imagine the other webinars, they are on the website now. So I think if you go on the website, it'll be with the other webinars, because as Donna mentioned at the beginning, this is the 5th one in 2022. And so, yes, it'll be there as the others are. Wonderful. Yeah, there's Anthony just assuring us that it will be posted on the YouTube channel and the website, and we'll be in touch via email when it is available. So there will be a message to CHNC members that this recording is available. So you will get it. Awesome. Well, we're just looking at the time. Unless there isn't any other questions, then we're thrilled that you were able to join us today to hear these results. So now I see your hands up, Cindy. I don't know if that's a question or it's just a farewell. So
no, that was
want to end it, Donna? Go ahead.
Okay.
Clap.
Well, I just wanted to say thank you so much for this research and for the presentation today, Ruth, May, Genevieve, sorry, and Kathy. It's really validating for me personally and professionally, and also to see that there's such similar issues across all provinces and territories in Canada. So that really struck me, and just what a wicked problem this pandemic has been. What struck me as well is the term repeated redeployment. There's 2 re's in there. Yeah, so it's, and I love the potential solutions. It struck me that all the solutions were, again, what more nurses could do to solve the problem. I didn't see a lot of self-indulgence in those solutions at all. So again, the empathy, the compassion, the commitment of nurses to solve the issues. They're dealing with moral distress, but again, they want to solve equity issues. So again, not selfless or selfish. So yeah, those are just my takeaways. Thank you so much for this time, the session, compiling the results, and I'm sure CHNC would be happy to help disseminate the results. And I look forward to your next session at the CHNC conference that has 150 registrants as well. We want to get it to 200. So thank you again for attending today. Happy National Nursing Week. I hope people take some time for reflection and celebration and further discussing with your colleagues and friends and family. Thank you again. Bye all.